So welcome to the webinar, Zero Breast Cancer's Peripheral Neuropathy, Dealing with Nerve Problems During and After Cancer Treatment. This is the first in our Health and Wellness After Breast Cancer webinar series. And I am Catherine Thompson. I am our Survivorship Program Director. I want to start out by saying that we are the Zero Breast Cancer Office and our staff are on Ohlone, Pomo, Wapo, and Coastal Miwok tribal land territories. We name these tribes to protect and honor the peoples of these places where we work and live. So Zero Breast Cancer was started 25 years ago, actually just more than 25 years ago, focusing on the many things that we can do to control our risk of breast cancer and our health and quality of life after a cancer diagnosis. Some of the things we can do on our own, while others require us to work together to address the social problems, unfair practices, and unjust conditions that weaken the health of specific Americans. And we hope that you will sign up for our occasional emails. It's usually no more than 2 in a month, to learn about our efforts to improve health and wellness, to reduce the risk of breast cancer and other cancers, and to lessen the impact of a cancer diagnosis. So at Zero Breast Cancer, we work to improve health equity throughout the cancer continuum by working with communities to develop culturally appropriate education campaigns. Pictured here, you can see our neuropathy fact sheets in English and Spanish. What is cancer-related neuropathy? And in the chat box, there is a link to find, to actually go to that fact sheet and read it. So these fact sheets, not only this one, but there's another one on memory, and we have more that are in the pipeline. And these are created in collaboration with women who are diagnosed with breast cancer and also with research scientists. The topics were chosen by culturally diverse survivors, and we have a number of other materials that are also available for free downloading from our website. We also share print copies with our partner organizations at no cost. And if you would like copies of our materials, the fact sheets or other things, please contact us, and you can get the link in the website, in the chat box. So let's start out with a definition of peripheral neuropathy. I'm going to read this out. This is from the National Institutes of Health. Peripheral neuropathy refers to many conditions that involve damage to the peripheral nervous system. The peripheral nervous system is a vast network that sends signals between the central nervous system, that's our brain and our spinal cord, to all other parts of our body. And the peripheral nerves send information to the central nervous system, such as the message that my hands hurt or my feet are cold. And they also carry signals from the central nervous system to the rest of our body. These signals can be disrupted in a number of different ways in neuropathy, and it can cause numbness, tingling, and pain. So I don't want to spend too much time on this because we're going to hear a lot more about what this specifically means. And after we have our speaker, then we're going to have a discussion with our survivors and a clinician. So it is my great pleasure to introduce Alyce Adams, who I first met when she started conducting research on both diabetic and cancer-related neuropathy at Kaiser Permanente's Department of Research. Dr. Adams is now the Stanford Medicine Innovation Professor, and she helps direct the Office of Health Equity and Community Engagement at the Stanford Cancer Institute. You can read more about her on our webinar page. And Alyce, if you would and share your slides.
Certainly. Thank you so much, Catherine. And I'm just going to, make sure my video is also working here. Thank you so much for having me today. It's such an honor and a privilege, and I really look forward to the conversation. As Catherine mentioned, I am now at Stanford Medical School. Prior to that, I was at Kaiser Permanente for about 13 years, working with the health system there. And before that, I was at Harvard on faculty doing similar work. Really, my motivation for the research that I do is to really potentially end suffering of communities who are burdened with chronic diseases like cancer, and in particular to address inequities in outcomes for those individuals. I'm not an MD, I'm not a clinician. My work really is in trying to leverage information, whether it's coming from patients or clinicians directly, or from electronic medical records or other claims data or large databases, to really understand what are the drivers of inequities in chronic disease treatment outcomes within health systems and at the population level, and then what policies and practices are likely to influence that. So I'm really excited to talk with you here today, and I really appreciate it. So I see my audio is a little low, so I'm going to speak up a little bit, and hopefully that will address it. Please let me know if it doesn't. Thank you so much. So as Catherine did, I also want to acknowledge that Stanford stands on the ancestral lands of the Ohlone tribe, and we want to offer a great appreciation for the tribe and for its members and for the opportunity to live and work here. So today I'm going to talk a little bit about who we are, our motivation for the study that we're doing in the cancer area, peripheral neuropathy, some preliminary work that we've done in diabetes that really informed a lot of this current work, as well as our approach to our current study, and then finally sort of opening it up to broader discussion. And hopefully, there we go. My slideshow wasn't working, now it is. Thank you. So who we are. I show this not just because I can talk to you about every single one of these wonderful people, but really to say that this is really a group effort, it's a labor of love of a lot of people, including several patient advisors, and that group is likely to grow over time in terms of individuals who have lived experience with cancer and with neuropathy, as well as clinical advisors. And I wanted to show you this list of this vast group of people, just to say that there's so many different aspects of the work that we're doing that really require the insights of different people from different disciplines and different backgrounds, and that we simply could not do this work without engaging in partnership with our patients, communities, and clinical advisors. So our motivation really is that about 2/3 of patients treated with specific types of chemotherapy, such as taxanes and platinums, will experience peripheral neuropathy side effects. What does that mean? Well, it depends on the person, and it's not always easy to know who will get these side effects or what they will, the impact that they will have on individuals. But sometimes people get these side effects during chemotherapy treatment, and we call that sort of this acute phase, where they may or may not have it after treatment. Once treatment is done, it may go away. But the reality is, for some people, if the symptoms are severe enough, they may have to limit their dose of chemotherapy because of the neuropathy symptoms, which is, of course, the last thing you want to see for someone who's being treated for cancer, particularly when it's being treated in a curative way. The other is that some people, unfortunately, experience symptoms that continue throughout the rest of their lives. And for some people, those symptoms can be disabling. And I think this area is particularly of concern to clinicians or oncologists in particular, because unlike in a place like diabetes, where we also see nerve damage over time, that nerve damage in diabetes is related to the diabetes itself, where in this case, the nerve damage that we're talking about is actually due to something the clinician has done. It's our efforts to treat and save the life of the patient that we may actually create this harm. And so for that reason, it really is poignant for a lot of our clinician partners to address this issue. Unfortunately, as I mentioned a moment ago, we don't know who's at greatest risk for having these symptoms related to chemotherapy, either acutely or over the long term, other than sort of what specific types of chemotherapy that they're taking. And so what that means is patients and providers then have to weigh the potential risks of neuropathy against the potential life-saving benefits of cancer therapy. And it's that trade-off, that very uncomfortable trade-off, that really is the center of our work and the reason why we wanted to do more work to understand what's going on in this space and to see if we might be able to at least inform decision-making on the part of providers and patients. So I mentioned before that we've done some work already in the area of diabetes, and in particular with diabetes, very much similar to patients in cancer who have these symptoms over a long period of time, is that you have the pain, the tingling, the numbness, sort of very unusual symptoms that can be hard to diagnose, and they tend to start in the extremities, so the hands and the feet. And often they can get worse over time. An estimated 50% of people with diabetes who've had diabetes for at least 10 years will experience some form of neuropathy, though not everyone experiences the same level of symptoms. So very much like in cancer, it's hard to know who's going to have neuropathy and then how it will affect their lives. Neuropathy, unfortunately, peripheral neuropathy as yet is incurable. So we don't have a way to actually end the neuropathy in terms of diabetes. We don't have a way to cure it. However, symptoms may be treatable. There are some treatments out there, though not everyone responds to the same treatment. And quite frankly, the symptoms are often undertreated in clinical settings for many reasons, including that it's hard to diagnose. It may be seen as something else other than peripheral neuropathy. Again, not everyone responds to the treatment, and some of those treatments can have side effects. It can be problematic in and of themselves. And then there are often challenges in communication between patients and providers about those symptoms. We often talk to patients who say, I'm having the symptoms. When I talk to my doctor, I can tell the doctor's not listening. And then when we talk to physicians about it, we say, your patients are saying you're not listening. And they'll say, it's not that I don't hear them, I don't know how to help them. And so what we end up is a situation where sort of nobody's happy with the status quo, but we don't quite know how to move things forward. So in our prior studies, we really identified what are the unmet needs of patients, and that there was lack of real-time data on patient needs that was being provided to providers in real time because of that lack of communication. So we had developed an intervention along with a number of other studies to try to bridge that gap by gathering information from patients about symptoms and side effects of treatment and feeding it back to clinicians. Unfortunately, what we found was that the intervention to provide data to inform practice and inform practice change among clinicians in terms of diagnosing the condition, treating the condition more readily, didn't actually change provider behavior. So then the question was why? Why is it that when clinicians had told us they want to know what's going on with their patients, and patients are so eager to give us the information, we still can't bridge the gap from information on symptoms and treatment to actually changes in practice in the clinical setting? Well, we think there are a number of different reasons why this happened. One is information overload. When we provided information from patients to clinicians about neuropathy symptoms and treatment, often the physicians didn't even remember receiving the information, even though it came to them as an alert within the electronic health record system, which is generally how physicians learn about what's going on with their patients outside of a clinical visit. They simply get so many alerts, they couldn't distinguish that alert from all the other alerts that they were receiving in a given day. Clinicians also expressed concerns about whether the information was really actionable due to the limitations of the available treatments. Specifically, particularly in older patients, one of the treatments that can be effective for neuropathy, some neuropathy patients, is tricyclic antidepressants. Yet, tricyclic antidepressants can be problematic to give people who are elderly. So, for example, one side effect is that people get very, very sleepy. Well, for someone who has at risk of falls, you have to be careful, right, about giving them something that can make them sleepy. And there are other issues too with those particular medications. There were also concerns expressed about the relative importance of treatment of symptoms of neuropathy versus the life-threatening illness of diabetes itself. Clinicians would say things like, I know the symptoms are bad and they're hard to take, but I'm focused on preventing stroke, or I'm focused on preventing a heart attack related to their diabetes and their underlying cardiovascular risk. So there was a weighing that physicians were doing of weighing the risk to lifelong survival against the need to address the symptoms. And so there was also a lot of issues related to clinical uncertainty. So they talked about, because the treatments aren't great And this is a symptom that, patients will respond to differently. The answers aren't really black and white. If they were black and white, I'd know what to do. So they would say things like, if the condition were serious, I use the quotes there because it was like the quote that we got from clinicians, if the condition was serious as opposed to symptoms, but if it was serious, then I would worry about it. So they were more interested in getting information, for example, if someone was having a bleeding event related to something like Coumadin, which is really to sort of prevent blood clots, right? And so we worry about giving people Coumadin because they could actually hemorrhage and they sort of have bleeding, which could then lead to risk of death. And so they were more interested in that because if they felt like it was something that was actionable and they knew exactly what to do, whereas symptoms felt a little squishy to them, and it was less clear how they could actually address these issues. What was really important here, though, was that patients felt a little differently. So when we also talked with patients who are experiencing these symptoms, and we asked them, what if there was some miracle drug, right, that came on the market tomorrow that was pretty effective in addressing neuropathy symptoms? What would be most important to you in terms of how it affects your life in terms of that treatment itself? And we asked them about all sorts of things, whether it was the cost of the treatment, the side effects related to the treatment, what the treatment was effective in addressing. And by far, this graph basically just shows preferences of patients. The dark blue line indicates the number of patients who sort of said, yes, this is what's most important to me. Most of them said specifically, if they were to take this drug, they want to know that they can do the things that they usually do, right? So their focus was on function above and beyond sort of a number of other things that the clinicians were worried about. They were also talking, though, and this was really important because this was what was third most important to them, was that they wanted to be talking to their doctor about these trade-offs, right? But before, as I mentioned, we didn't see those communications happening. And even when we did an intervention, when we gave the information to the clinicians still weren't responding by contacting the patient and talking with the patient. And so there were a number of other things that they also talked about, pain relief, side effects, et cetera. But really what came to the fore for these patients was I want to be able to function. I want to be able to live my life. I want to be able to improve my quality of life. That's what's most important to me. So in looking at this work, I was talking with some oncologist colleagues who were part of the Cancer Research Network, which is run by Larry Cushy over at Kaiser Permanente Division of Research. And I was talking with her about these findings and sort of my frustration about not being able to bridge this gap. And she said, oh, Alyce, you have to do this in the chemotherapy space. And she brought up this reason that I mentioned before. It's that in diabetes, what we know is that a lot of people will get neuropathy if their diabetes is not well controlled over time. It's sort of a consequence of the disease. But in neuropathy for cancer, because it's often related to the chemotherapy treatment that we're giving patients to help them, the consequences and the issues related to these trade-offs are even more poignant and even more important to address. So what we started out by asking in terms of our study, which is funded by NCI, is we wanted to know, how can we understand and inform decision-making about these risk trade-offs between chemotherapy-induced neuropathy and life-saving chemotherapy when we know that objective information based on our prior work isn't enough, right? We know that just providing information to clinicians isn't likely to get us to where we need to be about the risks and benefits. So how do we understand how patients and providers process that information and then decide to act upon that information in the real world? So focusing on more than 8,000 patients who are adults who are diagnosed with invasive cancers. Our goal really was to, and we chose breast cancer and colorectal cancer, I should say, because they're highly prevalent, but also because they're more likely to be treated with chemotherapies that are more likely to have this particular side effect of neuropathy or nerve damage. And so we wanted to know two things. One, we wanted to know, could we develop a risk tool, an algorithm, a model, if you will, that would help us to understand individual risk of either immediate, sort of severe chemo-induced neuropathy that disrupts chemotherapy, and or long-term prolonged symptoms. So that was the first question. And that's done using artificial intelligence and machine learning, which I'm sure everyone's heard about these days. But basically, it's using as much data as we can and leveraging the power of technology to be in, as well as with clinician and patient input, to help us better understand who's likely to be at risk. Can we do that accurately? That's our first question. Our second question that we're asking is, and we're doing this simultaneously, and we'll talk about that in just a moment, is we want to evaluate how risk information about neuropathy risk associated with chemotherapy is actually used in clinical practice. Who's using it, or who's likely to use it? What information do they need? And how might it inform treatment? Oh my goodness, and my computer screen just went out. My apologies. Hopefully you guys can still see me. I can still see my screen, but hopefully that works. Sorry about that. So in consequence, sort of in the conclusion, really what we want to know is when and how might such information be used? Who might find this information useful? What are the benefits and risks? And what are the barriers to improving care? In addition, we want to know what's ethical here. What's ethical in terms of the use of artificial intelligence in this space? So really, those are just some of the questions that I would like to ask all of you, because it's critically important that those individuals who are most affected by this are the ones involved in answering these questions. And that's really why I'm here today. And I really greatly appreciate the opportunity, and I look forward to the conversation. Thank you.
Thank you so much, Alyce. That was really impressive, the work that you are doing, and I hope that we will get some really good answers out of your research. Before we move into the questions, I want to go ahead and introduce the rest of our panel. Oop. I need to start it from where we're at. I start with Alyce and move down. Okay. We are honored to have three amazing women joining us, Alyce, for our panel discussion. And I'm going to, excuse me, again, their biographical sketches are available on our website, but I'm going to just give you a little bit of background. Deborah Butler was diagnosed with breast cancer in 2018, and she is active with our partner organization, Women's Cancer Resource Center, and she is involved with their sister-to-sister support group and program. And Deborah, if you want to go ahead and turn on your camera, and Alyce, if you don't mind turning your camera back on too, and actually everyone, thank you. Regina Guillory is a 5-year survivor. She advocates for the health of African American and all women, and she does this in part as a member of the Black Ladies Advocating for Cancer Care. And finally, but not least at all, Dr. Eva Myers is an oncology nurse practitioner specializing in breast cancer at Adventist Health White Memorial in East Los Angeles. And she has worked for several decades to provide quality cancer care to underserved populations. So I want to start out by asking some questions of our two survivors. So when did you first notice, both of our survivors, Regina and Deborah, have had neuropathy. And can you tell us, when did you first notice your neuropathy symptoms, and what were they? Regina, would you start?
Certainly, Catherine. Thank you. For me, the experience was almost immediate after I began my medication post-surgery. I had a lumpectomy, and I was prescribed A1 inhibitor medication that I refer to as a chemo pill, because I did not do chemotherapy. I only did radiation as part of my post-surgery treatment. The A1 inhibitor medication was prescribed by my oncologist in conjunction with the breast cancer surgeon, my primary care physician, and the radiologist. They were all in agreement that this was the best course of action. So again, almost immediately after I started the medication, I began noticing peripheral neuropathy in my feet, legs, hands, and arms. I also had some symptoms, although I did not have a lumpectomy. I'm sorry, I did have lumpectomy. I did not have the lymphatic area affected. They did check lymph nodes, but I did not result with lymphedema. There were some related pain and symptoms that I think the peripheral neuropathy triggered with my lymphatic system that was not due to the surgery, but actually a consequence of the medication. It was almost immediate, and it was like chronic, to the point where some days I could not walk. Some days it was just so excruciatingly painful, I didn't know what to do. So it was right after the surgery and starting the medication.
Oh, thank you. And Deborah, what about you? When did you first notice symptoms, and what were they? Oh, hang on, we need to unmute you. Can you? There you go.
Okay, thank you. So when I first started recognizing that I had neuropathy was when it was in the middle of my treatment, maybe about like 3 months later. And the signs were that I couldn't pick up and I couldn't feel like needles when I was sewing. And the difference between cold and hot. Cold was like ice, and it would like go to your bones, and hot was like really, really burning sensation. So that's when I first recognized it.
And Deborah, you were treated with carboplatin and docetaxel, that are two of the chemotherapy medications that are known to cause neuropathy. Did they change your treatment at all because you started having those symptoms? Did they recognize that your symptoms were related to the chemo?
No, they told me that those were the side effects. Those are the side effects of the treatment. So no, they didn't change my medication at all. No.
And did your symptoms improve when the chemotherapy treatment ended, or did they stay about the same?
They stayed about the same. They didn't improve at all. And I went to they gave me some pills for them, but then they didn't improve at all. It just kind of you start walking, your feet get number, it gets more intense towards the end. Mm-hmm.
And Regina, so you had told me before that you also had some pain from an injury before the breast cancer. Is your neuropathy worse in the area where you were injured?
Well, that's an interesting paradox, actually, Catherine, because I did have that injury a few years prior. One of the outcomes of that injury was a pinched nerve. And from the pinched nerve, it triggered radiculopathy. And
Can you define what that is for those of us who are not familiar with that?
well, it's interesting because to me, it's very similar to the peripheral neuropathy. A lot of the symptoms and the presentation of the symptoms is, for me, much the same. Although the peripheral neuropathy is much more excruciating. With radiculopathy, I noticed, because again, this was activated by the pinched nerve, I would have loss of feeling in one or both hands, primarily the right hand, because that's where the pinched nerve is on the right side, but then it would travel between the right and the left. I would drop things. I couldn't grip things. My hands and fingers would lock up, and they still do. They lock up, so it's difficult to know from one moment to the next if I'm going to drop things. So I have to be like quite strategic in what I'm doing and when I'm going to do it, because I don't know when it might flare up. And cold weather is a factor, you know, and warm weather, it occurs and presents differently. So I'm not a clinician, so perhaps Eva or Alyce can address that radiculopathy diagnosis and what that actually means. But as a patient who endures it and has lived with it all these years, it has affected my quality of life tremendously.
Eva, do you want to explain the difference between neuropathy and radiculopathy, or do you, or is it, for all intents and purposes, the treatment pretty similar? Eva, can you not hear me? You're on mute, Eva.
Let me unmute. Yes, I'm glad to meet all of you, and thank you for sharing your stories. And I'm the nurse practitioner here in the Cancer Center in Los Angeles. So I mostly hear the patient perspective too, so much like you are sharing. And I just want to say there, and what you're describing to me is just very consistent with what Alyce has already shared with us, that the medical team does not have answers to these questions. There is no standardized way to treat any of these, particularly in what Regina just shared. So here you are talking to the medical oncologist, and they're focusing on cancer, like Alyce described very well. They're not even focusing on the musculoskeletal piece. And when you say previous musculoskeletal injury or spinal injury or previous musculoskeletal pain, well, that's not my domain, you know, from a cancer oncology point of view. And it's literally impossible to try and get a consult from the orthopedic surgeon about the pain, and then get a consult from the medical oncologist about the cancer pain, and then those that have also diabetes get a consult from the endocrinology doctor about the neuropathy from diabetes. They overlap too much, and most physicians just do not focus and do not have answers on that. And that maybe helps explain what Alyce was sharing, that that's not a priority of many of the physicians. I don't have answers to that until you pinpoint where it's coming from or what's causing it. It's hard to address or to know which medical professional is the best one that can address. I think from current knowledge, from our current state of knowledge and current practice, you're almost going to get more answers in the alternative medicine world than in the traditional medicine world at this point in time. And that's why we definitely need more information about causes and identifying sources and all the overlaps. Peripheral neuropathy is painful, whatever the source is and whatever the cause is. And there is no standardized practice or treatment in the medical world at this time. I was reading last night, you know, what's the impact of low vitamin B? What's the impact of low vitamin D? What's the impact of turmeric in my system? And nobody even measures those to see how much they contribute to the symptoms of nerve damage. So we have a long ways to go before we have answers in this field. I wish I could offer answers, and there's not very many there.
That's okay. So that's one of the reasons we're having the webinar today, is to find out what is working for the people that we have here in the room.
Correct.
Or on the webinar. So that leads actually very nicely to my next question. So Deborah, what did the doctors recommend for you to treat your neuropathy? Did they give you, over time, did they recommend that you do anything particular, any particular medications or supplements?
Well, being a part, of the sister group, we discuss a lot of things. And so I learned that you could take B6 will help. Acupuncture, I went for acupuncture. It helped a lot because my toes, I had no feeling in my toes at all. And it really, that was the first result of feeling in my feet was my toes. But in between, there's no feeling at all. And also, I take medication for the nerve damage, which it helps. It just keeps it from getting worse. It's not taking it away. It just keeps it from getting worse.
That's very important though, because as
Right.
Alyce was saying, it can continue to get worse. So.
Right.
And if I remember correctly, you told me that the medication that you're taking now is a Cymbalta, also known as duloxetine.
Right.
And I'm wondering though, are there other medications that you're familiar with, either anyone else? I have heard that opioids are not very useful for neuropathy. Is that true?
I haven't tried it. I just take what the doctor says and the B6, and I try walking, but I know it's there. And I just try to deal with it on a day-to-day basis. Yeah.
Regina, what about you? What did your doctors prescribe for you?
Well, my medical team, as I said, consisted of my oncologist, my breast cancer surgeon, my radiologist, and my primary care physician. And I consulted all of them all the time throughout this journey. And that was helpful to me because they all had a different perspective and vantage point. And then I could make an informed decision after talking with them and researching. So because the pain was so intense and so pervasive, I knew the corollary was the medication. So we tried different medications. That was the first attempt to address it. So the first medication was excruciatingly painful. I went to the one that I'm on now, and it was less so with the symptoms, but yet again, there were days I literally could not walk. I would stand and my feet were like numb. I had no feeling in both feet. So when the oncologist understood the severity of that, I was told to stop taking the medication. I did that for 3 to 4 weeks at a time. But with their guidance and my doctor's consent and awareness, ultimately, after 3.5 or 4 years of doing this, I was trying the different modalities as Deborah shared: acupuncture, massage, deep tissue massage, aquatic therapy. Most of the things that I was trying were not medication, but they were alternative medicine interventions that alleviated the pain and gave me relief. Both my oncologist and my radiologist said, Regina, diet and exercise are the key. Honestly, look at your level of activity and try to intensify that as best you can with the pain that you're enduring, and look at what you're eating. I noticed that salt was a factor. If I eliminated salt, it was amazingly impactful in a profound way. It was difficult because I salt all of my food. I love salt, didn't realize how much so, but I began to eliminate salt, and it was really helpful. Increase my water intake. Hydration is vital. I had to drink a lot more water, and it really did make a difference. The final thing was turmeric. My oncologist finally said, and we had researched and talked about this for 2.5, 3 years, but she finally found a product and gave it to me during one of my appointments and said, here, take this and let me know how it works. It was almost immediate relief. It was amazing. And coupled with the medication I was taking and the turmeric, and I heard Eva say that precautionary comment about we don't know how much turmeric is too much turmeric or what's, because it's not regulated by FDA. There are no guidelines, but I know my body fairly well, and I know how my body responded to that turmeric immediately, and it gave me tremendous relief, and it still does. And I'm very thankful that my doctor referred me to that, and it's helped immensely.
Well,
Can you share with us, do you take turmeric tablets? I'm sorry, Regina, can you clarify, is it a pill form, a tablet? Is it a protein? Is there a certain brand?
You can't see this label probably, but it's by Science Natural Supplements, turmeric platinum, bioperine, 1,300 milligrams. She advised me to take 2 a day with my, what as I call it, chemo pill. And I cannot express to you the tremendous sense of joy that I experienced knowing I could be causing the matter with this supplement to alleviate some of my pain and function with my
believe you.
family, my grandchildren, and walk and enjoy life more again.
I absolutely believe you. Food
It
is
didn't
medicine.
eliminate all the pain, and I still have peripheral neuropathy, but I feel I have something that can help me, and it does. Thank you. Thank you, Eva. And Alyce, I know you understand because, and Deborah, you too. I mean,
Yeah.
live life experience that we are sharing and talking about today. It's so real. And to be able, as a layperson with no medical training, to actually find something, because I began to research more extensively. Once the doctor gave me this, I began to check I went to every, GNC store and checked every website, Elevate. I'm on every, different resource that I could find for turmeric, and cumin was another one that they recommended.
Right. Curcumin and
Curcumin.
turmeric. Curcumin and turmeric. Turmeric is a curcumin.
I see.
And so, yes, those are anti-inflammatories, and those can be useful for a lot of things. And that is amazing how well that has worked for you, Regina.
Yes.
I know that we've been getting some questions in the Q&A, and so I want to make sure that we ask those as well. Someone else, unfortunately, a number of people have written that their doctors have dismissed their symptoms, just have not listened. And so I think you're sharing your stories is really powerful, and having 2 experts here who really understand and acknowledge that this is such a severe problem.
Yes.
But one of the things that somebody else wrote in is that they use gabapentin. And I know that that is prescribed for nerve damage as well. So I guess that's another possible one. Another person asks, can cannabinoids help? So those are the things that are extracted from the cannabis or marijuana plant. And there are a couple of different things that are different chemicals that are extracted from there. And Eva or Alyce, do you have any idea if there's any good evidence out there about cannabinoids?
Haven't seen any yet. It doesn't mean that we won't see it. One of the challenges in our research is that for folks who do study medicines, that's been an area that's been very hard to study for all sorts of reasons. Some of them scientific, a lot of them political. Increasingly, I think there's been more interest in studying those in a systematic way. And so we'll see if we get some really good results. I will say for both of the gabapentinoids, the gabapentin, as well as the tricyclic antidepressants, which is like the duloxetines and that sort of category of medication, not duloxetine, yes, duloxetine. Those groups are the ones where we probably have the most evidence of support for efficacy. Efficacy in those, when I last checked, was about something like 30% of patients will get about a 50% reduction in pain. One of the things that we found though with those studies is they primarily only focus on pain as the primary outcome. So they don't necessarily look at quality of life and function, which are some of the things that we've heard people talking about today. It's not just about the pain. So that's part of it, is that our science is inadequate because we haven't looked at the outcomes that matter most to patients. The other is that there's a lot of variation in who responds to those treatments,
Yes.
which makes it incredibly difficult for a clinician to know ahead of time. And for both of those treatments, because they have their own side effects, particularly as you get older, particularly with the antidepressants, there can be challenges with prescribing those. They generally suggest that you titrate over time. So you start at a low dose and then you go up. What I will say in our diabetes neuropathy study is that we found that most people got the first level for gabapentin, for example, or for duloxetine. Then they were supposed to ratchet up to a dose that was actually therapeutically effective. So in other words, you get to a certain place where like, okay, this is the ultimate dose that we really want to see people on based on the research. 50% of our patients never got to a therapeutic dose, even though they were taking it every day, right? Talk about disconnect in communication. So basically what was going in, the patient would go in, they would talk to the doctor might give them a script for gabapentin, they would take it home, the patient might come back or might not and say, hey, you know, do I go up now? And because they weren't having these conversations, they never got up to a dose that was actually going to help them. So that's one thing we got to stop doing, right? To giving people medications that aren't doing them any good because we never get them to the right dose. But the other is a lack of communication about the treatment and how it's working for individual patients, but it can be helpful for some patients. Opioids are very problematic, as all of you know, for all sorts of reasons. I know a lot of people were, about 50% of our patients who had diabetic neuropathy were on opioids. However, I think the evidence has actually suggested that that's not what patients should be on for neuropathy. And again, I'm not a clinician and I don't study I don't develop drugs, so I would sort of put those caveats on it from my review of the literature. The opioids, while some people ultimately do have to be on those for various reasons, there are legitimate reasons to be on opioids, there's all sorts of reasons to be cautious about opioids. And so I would just sort of say, definitely talk to your clinician about what's right for you.
So Deborah, did you have good conversations with your healthcare providers then about taking duloxetine, about the medication that seems to have leveled it out? Did they listen to you? Did you have to keep increasing the dose?
I did. I asked my doctor to, even if she could increase it to make it work, because I told her, you know, I can't use my hands, my feet are numb. I'm starting to have a hard time to walk, and it was difficult for the shoes I was wearing. I had to change everything. In the ways that I do things, I have to stop. But I asked, but there's actually, she still told me where I was at my limit. So she couldn't take it. She couldn't increase it.
Right. Actually, we've had a number of people talk about things like shoes and creams and all. So I would like to actually go ahead and share my screen again and show the next slide that I have, that is one that, Deborah, you had shared a number of things that worked for you. Would you mind just giving a quick overview of the different things that seem to have helped you?
Okay, so I wear shoes that are very, very supportive, that they fit my feet. They're all from the toe to the heel. And I have the shoe with the strap. I pull it tight to support, and it holds my feet in place. And then with the other shoes, they're casual shoes, and they're very, very good for even walking around the house, because I can't find slippers that are firm enough with a good grip to walk around the house in. And then I also use socks to help everything to stay in place. With my tennis shoes, I make sure I pull that string tight enough, not real tight, but tight enough to support my whole feet. I wear and I use compression socks to help my circulation in my feet and in my toes. And then I use the peppermint lotion, I lotion my feet before I walk, and it gives you a lot of circulation when you're walking. And also the tape I use, I cover the numb part of my feet. It's the part with no feeling, the heel of my feet, and sometimes in the middle. And then I put my socks over it, put my feet in my tennis shoes, tie them, I have a nice grip, and it helps to support and stand, and you can stand stable. It lasts a while. You can do your walk or whatever you're shopping, and you can be comfortable, and it helps you to keep your balance while you're walking. Now, the neuropathy oil, I use that to help me to relax at night and meditate and read. So that's what I use that for relaxing at night. And also, when I have time, I soak my feet in warm water and put a few drops of lavender oil in the water and just relax. And just, close your eyes and just relax and meditate.
Yes.
Oh, and that, just that mindfulness, the deep breathing meditation, all of those things can be so helpful.
Yes.
Right. And also, I have a hard time because I can't feel the holes in my ears. So I end up using mismatch earrings that works for me. Whatever ones I can get my earrings, the hole through is the pair that I wear. Just wear mismatch earrings. It doesn't bother me at all. And also, so when driving, especially during the winter, you get in your car, it's cold. When you touch the handles, the doorknobs on the door, it's freezing. And if I touch that doorknob or that steering wheel, that cold seems to go right to my bones. So I learned to use the gloves. I keep them in my purse, in the car, and when I go in and out the store. And also, I like to knit and crochet. So in the store, they have these crocheting grips, the grips, and then you just cover your crochet needle with that, and it helps to get you to get a grip, because the needles they're old-fashioned and they're metal and they're cold. So you want to feel that while you're trying to crochet or knit. Mm-hmm. And then I use for the pencils also, I just need a grip. So it gives me a good grip when I use the pencils, pens grips. Then also when I'm working in the kitchen or trying to cook, I use the mitt. These oven mitts have a grip on the inside that help you so you won't feel the cold or the hot. Some of my pots have the handles with the grip, and some of them don't. So I have to make sure that all that's covered, because if not, you can burn yourself and you won't feel it. Mm-hmm. You won't feel it. And another thing is you should never walk around barefooted, because if you step on something, you're not going to feel it because your feet is numb.
Right.
So important. Oh, thank you. That the safety is incredibly important.
Right, it is.
And we have so many more questions in the Q&A. We aren't going to have time to get to all of them. We have answered some. We will try to answer some more of these. I do want to just mention, one person was told not to use turmeric supplements, which is interesting because I have read up on it, and I think you'll get different opinions from different experts and different doctors. What I have read recently was that there were not any bad effects being seen. There were no negative side effects in the clinical trials that were being done, but there may be something that is out there that I haven't read. So I hate to say it, but our time is about up. If we can impose upon our panelists, I will ask you some follow-up questions in an email, and we can include those with the video that we post online. Everyone will receive a copy of that. I really want to thank our amazing panelists for sharing your stories, your expertise. I think that, you know, hearing from people who have actually been through these issues is critical, and seeing what actually works for people. So I want to remind folks, please, to sign up for our email, and we would love to also have you connect with us on social media. And finally, we are going to have another webinar this fall. We may have another one in between, but at least this one is definitely planned about heart health after a cancer diagnosis. And while it's about breast cancer, this is also relevant to lung cancer and many other cancers, because it's actually the leading cause of death among breast cancer patients after 8 years from their diagnosis. So, except for metastatic. We do have previous videos that are also available. Check them out on our website. I want to thank everyone for coming. And again, thank you so much to our amazing panelists for sharing your wisdom, and also those who asked questions and shared your wisdom there. After this webinar, you will be receiving a survey, so we ask that you please fill that out. We would love to hear about your ideas for future webinars and for what works and what we can improve. Thank you so much. Thank you, Deborah, Eva, Alyce, Regina.
Thank you. Thank you.
Have a good day.
So.
Thank you.